Welcome to one of the latest sessions of today here. And I think it's an exciting session. It's about some complexity. So it's not really a starter's level. The title is Defying Complexity, Achieving Optimal TAVI Procedural Outcomes in Challenging Anatomies with the new Evolute FX. So what we want to show here, what we hopefully can present to you is an introduction. What is new with the Evolute FX system, the new system, which has been launched in Europe only 2-3 weeks ago. And then Darren is also going to guide us with CT, and I also have the honor of having Stan and Tobias Zeus also here. So let me very quickly go through the session objectives. First of all, to appreciate the new features of the new Evolute FX TAVI system, to learn how to bring the best out of your cardiac CT. That's Darren's job, and I think he's going to do that based on a case that Tobias is afterwards going to show. That's a challenging case he did probably only 1 or 2 weeks ago, I guess.
Yes, 2 weeks.
Yeah, 2 weeks ago with the Evolute FX. And then another case, I was confronted with a complex case, also with the Evolute FX, and how I think it helped us to get a real good treatment for this patient, also in a complex anatomy. So before we start this session, I think we have to say, we don't want to stand here talking only from our side. We have these mic boxes. Maybe from those of you who have been in this forum, you can talk about in this mic. So maybe I can throw it to anybody. I can throw it to you. Yeah, take it. Yeah.
Good catch.
You can try to talk in it if it works.
I think it's working.
All right, that's great. Good. So if you have any comment to make or any question or any remark or any good thing you want to comment on a case, just please raise your hand, or we're going to, in between, throw these boxes also to you. Yes, yep. Darren?
Yeah, so I think that's important. So we're going to start this session. We're going to have you guys talking to us. None of us here, maybe with the exception of Stan and maybe some of our other friends from the United States, have great experience with FX. We're all learning a little bit together. And so if you have a particular case that you've experienced, or you have particular information or whatever, share it with us. And we're going to do that by throwing these boxes to you. And so be careful down the back, especially if you're down the back. Don't be on your phone, because if you are, you might get hit in the head by one of these devices, huh? So stay awake. Okay, Ole, over to you.
All right, good. I think we give the word immediately to Stan. Yes, you have the honor to introduce the Evolute FX.
I like this system. I can't hide how fat I am and how bald I am in this arena. Everyone can see everything.
Okay, good.
So thank you, Darren. I've been doing FX on the 22nd of June last year, so we have, as you said, a bit of experience. We're going to describe the new features and benefits. Here are my conflicts. The Evolute system, although it looks very similar to the old Evolute Pro, has significant changes in features. Number one, they have the redesigned tip that looks and feels more like a dilator on a sheath. There is a redesigned capsule that has been pre-formed. It's kind of been developed so it is more flexible. And then, paradoxically, even though there's a single shaft, the optimized stability layer, now in green, is more rigid. So as the device comes in, for those who have used this already, you might have noticed that rather than sit on the lesser curve, it sits on the greater curve. The stopcock has changed slightly. And then there are these 3 famous dots. And Darren might remember that I was not in favor of these dots many, many years ago. But I have had to eat humble pie, and I think not only do they help us see the depth of implantation, but we have also realized they have a significant role in confirming our commissure alignment. If you look at the two systems side by side, number one, the guide wire selection, I think because of the stability layer and how the device is performed, the importance of the stiff wire we used to have, the Lunderquist, is no longer as important. I think now 70% of the cases are with a Safari or a Confida rather than a Lunderquist.
Stan, why don't we just, can I just see a show of hands? Who uses routinely a Lunderquist to do their FX or their Pro Plus cases? And who uses routinely another wire, be that a Safari or a Confida? So I think this is the big difference between the US and Europe. We never really got there, most of us, and some of us did it for particular studies, but I certainly felt more comfortable using a Safari than
I realized.
So I'm happy that this is a change, that you think it's no longer necessary.
I was 100% Lunderquist, and I'm now probably 70% non-Lunderquist.
Okay, you're on the way down. You're improving with time.
I had to,
like a
because
good
of
bottle
you
of
guys,
wine,
with an
Stan.
optimized pro. When the Europeans came on, we had to try and see what you guys are doing and come on online with you guys.
Okay.
They had to adapt for the Europeans.
Yeah, we adapted. I am European myself, by the way. I'm from Malta. So leave me alone.
You're Irish, in fact, right, Stan?
Partially. The commissural alignment still the same concept. We go in at 3 o'clock, you quarter turn at about 30, 40 LAO in the proximal descending thoracic aorta. We check to see the head marker, adjust accordingly. Here it says, in the slide it says clockwise. I have found that the vast majority are a bit of a counterclock to about 2 or 1 o'clock. Then you come back down. And the one big difference, when I say big, I'm overplaying this, is that whereas with the optimized pro, we were taught to start, because it's going to descend from the mid pigtail marker down into the position, we start lower because there's less movement and much more stability. Another important point I found.
Then why is that? Because I want to understand, or that everybody understands, like, why do you start and need more at the point where you really want to be? Is it because of the longer stability layer?
Longer stability layer. It's also leaning towards the greater curve, so there's more symmetry as it opens, and there's less. The force of the release is less inclined to push it into the ventricle, so it stays where you start from it.
Okay.
And then, last but not least, and I think it is important not to cut a corner. For those of us implanting in cusp overlap, we're happy with the depth, we want to be low. And I'm not sure, maybe it was my technique, but we always had this kind of asymmetry of 2 and 5, 2 and 7, non-left. I mean, maybe it was different where you implant, but
a little bit lower on the left.
A bit lower on the left. And so if you're like 2 or 3, sometimes you want to cut a corner and not go towards the left and check. But because there is this concept of symmetry with this valve deployment, it is important to check on the left, because you're really high on the non, you'll be really high on the left. And that was one of the take-home messages that our nurses, as we did our registry data, we're always implanting depth of the implant, whatever valve it is. My research nurse came to me and said, are you guys making up numbers now? Because it used to be different. And now it's the number of times that we're 2 and 2 or 3 and 3 or 1 and 1 is consistently about 70% of the cases.
Okay, that's interesting, because I must say, since I've been using it a couple of weeks, I've struggled a little bit with that. I haven't got that really nice depth on the left-hand side. So I'm gonna pick you up on it as we see Tobias's case and see, can you give us some tips and tricks to try and understand how to get it, as you say. Okay. Maybe before we go on, I know you're going to keep going. Who's done an FX case? Okay, who's done more than 10 FX cases? Right. Okay, so you guys are going to help us during the.
But do you think? I mean, I think that's what I made the drawing. I tried to correct me if I'm wrong, but that's the feeling that I had in my roughly kind of 10 first FXs. The difference, but because that's maybe also not everybody appreciates that. What does it mean there with that single spine or double spine? Can you do it with your hand, like
like, I mean, the old Medtronic slide was that the old Evolute Pro, you could only do this but could never do this. There's only one range of movement.
Yeah.
With the new FX, there is more flexibility.
You can do like this with a catheter, yes, but in the past with the Pro, you were limited. You couldn't do it in one direction. Yes?
But also, because of the stability layer, so 2 things. I think the drawing is good for the Pro. If you look at the drawing, I would lean a bit more towards the greater curve. Even more. So it's like, that's why it negates the need for a Lundequist, because it does what the Lundequist makes you do with the Pro kind of thing.
But that was the problem, yes, in a cusp overlap, depending on the anatomy of the patient, I don't say in all of them, but depending if you had a bad anatomy of the patient, from the aorta that determines, the valve was arriving in not the best plane, because then the valve would open up indeed in this kind of way, so you would end up too low compared to the annulus plane. But now indeed, because you have that more flexible catheter, you can easily, I think it arrives in the cases that I did, the limited, it arrives more kind of vertical, but then if you even expand, it has more, it tilts in a good way, so you can actually really more centrally, equally, symmetrically. That's also what Gilbert Tang's data shows.
Yes, and I published an abstract this afternoon. I spoke this afternoon. We had 77% of our cases in the first 536 had a symmetry of less than 1 millimeter.
Exactly. So that helps.
That proves the point.
Great.
So when you guys are done with that little conversation, we're going to have a chat over here, right?
Okay, go ahead.
Have you found the same thing? Have you found that it's a little more coaxial in the way it comes around the arch, Christian?
True, yes it is.
You got to hold this.
Thank you.
There you go.
Yeah. So actually, the predictability of height is one of the major advantages. We'll come to that maybe later. But the coaxiality is much better compared to the previous Pro Plus.
Yeah, I agree.
And you think that's because of the stability layer, the spine coming out now, it's coming around in a different fashion along the aortic arch?
Difficult to answer, but the new flexibility, so the advantages of the new shaft, you see that also when crossing the arch. It's amazing in different anatomies, these crazy Gothic arches, where the valve just crosses like hot butter. Yeah.
Okay, so
Darren, may you perhaps ask again? So what I also think is, what do you think about the 3 dots, if you have them here, helpful or not? Because we are not on the outer curve where we really see the millimeters really in the center.
Yeah, I think the dots are a little interesting, I must say. So we know the dots are at 3 millimeters, and that gives us the implant depth. And I would say that in my first cases, I'm actually implanting a little bit lower than I used to, because I'm trying to get the dots under the annulus rather than at the annulus. So I think I have to relearn a little bit what 3 millimeters is, because the dots now show me the 3 millimeters. And I think I've got to relearn to get those dots at 0 rather than get the dots underneath, because I'm used to getting a bit of the valve frame underneath and I'm happy. Now I'm getting the dots underneath, but I don't want the dots underneath. I want the dots at 0, because that means I got 3 millimeter depth. I don't know, Stan, if you had that.
So I was not a big dot adapter in the beginning, because the dots are pericommissural, and what you're seeing in the non-choric cusp, in the cusp overlap view, is not the pure commissure at that point. So you're trying to aim the dot to something where the dot is not supposed to be. What I found the dot, but it does help, and I still go by the frame and the dot, and I use the dot to help me. What it does help, what the dots do help me in those cases where you have those. You probably describe a few where you're coming in and the cusp overlap view is very steep, Parion, steep caudal, and the aorta is kind of unwound, and then you have some parallax as you start to deploy the valve. You can see the dot where you've lost parallax. At least the dot shows you where you are in relation to the part of the annulus where it's.
I think the dots are helpful. No one has mentioned the color change. Right, we've gone away from this slightly dull blue and slightly dull gray, and now we've got some fluorescent green. You know,
like this.
It's interesting. It's good to have a new color.
It's coming from Galway, right? So.
Oh yeah. Okay.
So just to finish my part, the commissure alignment overview, which I'm sure most of you are aware, but I'll just go over for the sake. Insert the delivery system of flash point at 3 o'clock. We confirm alignment at the descending thoracic aorta. The head marker has also to be on the outside. Head marker on the greater curve, just above the valve. And then this concept of 2 dots in one. And basically, as you look at the picture, that 1 dot needs to be towards the right of the screen as you're looking at it, or the left of the patient, 2 midline or more towards the non-coronary cusp. And if you have that kind of configuration, we have shown in our series again that we have achieved commissure alignment proven by CT in 94.6% of cases.
Tell me, so about commissure alignment. This is the thing I think that is most dramatic with this, apart from the color change, is that literally taking the system up to the top of the descending, in LAO, to get that hat marker on the outer curve, you can now do with literally 2 fingers. It's like a tiny little bit of anti-clock most of the time, and it's immediately there. And then you hold that, push it around, and it remains on the outer curve. I've found that's a huge difference in my practice. Literally with 10 cases experience, very small, but that commissural alignment that you do in the ascending is now universal. It's done. It's done in 3 seconds.
And can I ask you, have you seen the need to do something beyond that as you come down to the above the valve?
Yeah, no, but I've actually had to relearn a little bit, because what I used to do with Pro Plus is get it on the outside and then kind of continue to turn it as it went around the arch to try to get it on the outer curve. Now, if you do that, you overturn it because it's quite sensitive. So literally, I just turn it on the outer curve, hold it, and bring it around.
And not to sort of control this discussion, but the one thing that's different, I think, is as an older person who've lived through the Core Valve Classic into the Pro into
You're not that old.
Oh yeah. All these maneuvers we used to do with the catheter before, pulling and pushing. Now the truth is, as I teach my fellows and trainees, just let go. So you're about to go slow to release and just let it go. The valve auto-centers. And I've joked with the engineers from Galway, and I said, you guys always promise And maybe sometimes we complain, but this time you under-promised and over-delivered. And I'm really very happy with this advice.
Okay.
Okay. Good. You have completed your slides, yes, I think? No, you still have one more. But that's about the computer line.
Again, yeah, and we said this already. We've discussed this technique, we've discussed how to start, begin at the marker, at the bottom pigtail, we've discussed in the beginning, approach the treatment marker from above. This is debatable among many implanters. We still do it. I like the consistency of no beat-to-beat variation by pacing about 130 to 140, and then release the system tension very, very slowly. So let go. And
but otherwise, slow. Then you do the same kind of step as you were used to do. Yes, same views, same kind of pacing, same kind of, yeah, that's all kind of the same. It just optimizes. What's important, I think, it optimizes how the coaxiality, it optimizes how symmetrical you can make your implantations. It improves your deliverability, trackability over the aortic arch. That's kind of...
And I don't want to overplay this because we'll be proven right or wrong, but anecdotally, we feel that the paravalvular leak, because there's symmetry and how the valve deploys, is going to be less, but I'll wait till we publish our TVT and STS data, because that's the gestalt I feel right now, but I'm not sure. I wouldn't want to overplay it until we prove it.
No. Okay.
So questions for Stan about the system? Anybody got any burning issues in terms of how it reacts, how it behaves, sizing, implant strategy or steps? No? Okay, well, we're going to go through those when we see Tobias's
Otherwise,
case.
during the cases, we can further discuss, and that will be interesting because I'm sure some people will disagree with some approaches that we did, or for sure in my case, I'm sure. But let's go first to the MSCT, the CT analysis. Darren, maybe you can, what we can get out of there for the case of Tobias' case.
Yeah, so maybe what we might, do you want to show us the case?
No, it's first CT.
Oh, we show the CT first. Okay, can we get the images from the CT scan up? So this is the case that Tobias is going to show us. And I think the first thing to do is always just drive through the CT. And so we see that already there's a little bit of annular calcification. As we come up, we start to see that we have a fusion between the right and left coronary cusps. So we have a raphe. This would probably have been called in times gone by a functional bicuspid, in that there's a calcium bridge between the two. But again, as we come up a little bit further, we see that part of this raphe is fibrotic and part of it is actually calcific. So there's clearly a raphe there, but this is a three-sinus aortic valve, but with a Sievers left-right fusion. In terms of calcium, it's probably on the moderate to severe range. With Tremencio, if we want, we can add the calcium volume. Where am I? I don't see it here.
Lower down.
Hang on, has it reset itself? But ultimately, a three-sinus calcific aortic valve that's probably bicuspid. We can look at the calcium on this hockey puck view. You can see the raphe coming down, and we can see that calcium extending down the LVOT. If we go to the size, first of all, we can see here that this is a perimeter of 84, 85 millimeters. That puts us in the range of a...
but don't say that, don't put that, because that's maybe interesting.
It puts us in the range of an Evolute FX.
I think it's interesting because it's rather large, but on the other hand, bicuspid. Can you walk through the leaflets again?
Yeah.
To really see how much calcium there is? Yeah, okay. So who would, I mean, it's clear. So who would go here for 29 and 34?
Let me give you some extra information first, right? So intercommissural distance at 4 millimeters is something very often that people use. So let's give you that. So if we go from one commissure to the other, so we see 26. Some people like it a little bit higher. So let's go 28, and we do the same thing. Okay, so intercommissural distance between 25, 28, depending where we are. What I like to do with these, if I'm being honest, is to have this show always function, and then I'm going to come up to the point where the valve is, the annulus is at its most calcified, or the leaflets are at its most calcified. And so here we still have, in this view, we still have the annulus. And so how much of the calcium here is going to be abutting into that annular plane? And so I would draw something like this. This piece of calcium over here is on the side, so it's not relevant. And I would think that the annulus is unlikely, the valve is unlikely to extend all the way over here because of this big chunk of calcium that sits in the middle. So I would do something like this and say, all right, well, this is probably what it's going to be. So a supraannular perimeter, I would say 79, 80. So probably putting it in the range of a 29 valve versus a 34. Some people like to use the Casper method, which is taking into account the amount of calcium and the length of the raphe. We can measure the length of the raphe here. So the raphe is 15. It's more than 50% of the perimeter-derived diameter. The calcium here is moderate to severe, so we take away 2.5 millimeters from the perimeter-derived diameter.
And the aortic root for the rest, SOV, ST junction.
Yeah, I'll show you those. So therefore, a Casper would have this probably just about in a 29 millimeter as well. If we think about the other things that Ole mentioned, and we go up and we have a look at the sinotubular junction and the sinus of Valsalva, they're large, sort of 33, 36 by 33. If we go and have a look at the sinotubular junction up here, that's not it.
Pretty big. But that's too high.
Here, yeah, it's nice and big. And then in terms of the assessment of the coronaries, let me just get rid of this for one moment. If we assess the coronaries when we move up, what I like to do is two things. First of all, by the time we get to the left main, which is joining here, we can see that there's almost no leaflet tissue in front. Therefore, the risk of having leaflet tissue coming in front is less. We come up to the level of the right coronary. Again, there's no leaflet tissue. And so in terms of coronary heights, we've got 19 on the right, 14 on the left. Last thing to do, obviously, is always to look at the implant view, particularly with bicuspid, because they can be very horizontal. This is our 3-cusp view, which is, which is LAO 17, cranial 8. The software will automatically give us a cusp overlap view, which is RAO 4, caudal 12. And one last thing I would advise you to do with your bicuspids is pre-dilate in a particular view. If you've got a left-right bicuspid, like this case, what you want to do is you want to line up your C-arm so that it is perpendicular to the most severe piece of calcium. And most of the time when we do this, we end up being an RAO caudal. So the cusp overlap view is very, very close to the best view for a pre-dilatation in a Siever's left-right bifurcation, which is 75, 80%. Why do we want to do that? We want to make sure that our pre-dilatation is effective, that it really has opened up the anatomy, and it makes the implant much smoother. So maybe with that, Tobias, I'll hand over to you.
Yeah, one more question to you. So do you always do this Casper calculation? Because to be honest, I don't do.
Yeah, I think the more information that we have, the better. I don't think that we know at the moment which is the best way to size a bicuspid. Some people prefer annular sizing and only annular sizing. Some people only supraannular sizing. I think integrating as many different sizing modalities as possible, really looking at the supraannular space, having a look at the calcium on the valve, I think is really important. Do I use it all the time? No, because I don't know that it's more effective. Sonia Petronio is engaged and has already recruited some 60 patients in a specific study to look at the Casper algorithm. But I think the more you look at it, the more you can get a good feel for whether the valve that you thought you were going to choose is the right valve.
I think the answer is also just, it's not one single method which is the correct method. We kind of do all of this, what you show. We do the annulus, LVOT, we do intercommissural distance at 4 millimeter, at 8 millimeter. You look to the aortic root, you look to how calcified and long that calcified raphe is. You maybe make such a kind of a simulation of a circle. So it's a combination of these things. It's not just one measurement I'm going to rely on to make my...
So let's go back to the audience. So tell me, who's got an opinion on whether we should take, well, we're between a 29 and a 34?
4.
Gintis, tell us, what are you going to do?
Well, there are a number of cases where both would work. There's also such a thing. And here, actually, even if this was a tricuspid valve, at the annular level, your maximum diameter is only 29. It's not very elliptical. So if you put it high enough, even if it is a tricuspid valve, even if this calcium breaks, because I'm personally not convinced it's a bicuspid. Ascending aorta is not dilated. You kind of, when you walk through, you see the rims of both cusps. I agree there's a calcific bridge, but I would also speculate it may open, like a normal tricuspid would. But even then, if you take 29 valve, I'm also pretty convinced it will work fine, just fine, because at the annular level, max diameter only 29, The only thing I would do, I would go not at 3, but at 0. I would aim high.
Aim high. Okay. Anyone else like to tell us about how they would approach this particular patient? Or will I just throw this at someone? Oh, look, there's my friend, Henrik. Tell us.
I probably would go for the 34 millimeter valves, and therefore I would love to see the dimension at the LVOT area at -2 or -3, just to have an idea if the LVOT opens up or stays in a like tubular shape.
So that's -3. Let me. Do you want a perimeter or do you want a mean diameter?
Yeah, perimeter, I think, yes. So you want to track it.
So we are not exceeding 29 here, so the reasonable choice can be the 29.
Perimeter 82
so
again.
It's absolutely a borderline case.
Yeah.
Yeah, probably both work. Anybody else? Yeah.
Oh, thank you. In this particular case, I think it's. I agree that either valves may work. What I personally would do is do an angiogram with a 23 balloon. In the view, maybe 23 plus a little bit, and if there's no leak in the after the aortogram, I would probably choose 29.
Okay, so balloon sizing to help you a little bit.
Yeah.
Okay. How do you feel about in bicuspids the risk that sometimes you get a little bit more tearing of the leaflet and you can get AR? In your experience, is this common or?
I think it's with Evolute. If you do a higher implantation, for instance, this is a calcified raphe, so obviously there will be some paravalvular regurgitation in this particular case, whatever you do. So, but if you do a higher implantation, you may seal that in the left-right raphe carefully. And I probably go with a 29 valve based on what the anatomy is.
Okay.
Are there any strong believers in 34 who is convinced I would only take 34? Is there anybody? Because we would like to hear the argumentation for that.
Well, it's me, but
yeah.
Okay.
You can use 34, so we're going to hear the argument.
So then you can comment on it. Yeah.
Let's be honest. If this wasn't the study when we studied the old core valve in bicuspid, the screening committee would have told us to put a 34.
Yeah. But I don't think there's any penalty here, right?
I don't think so.
You've got large sinuses. Your coronaries are not at risk. We're going to hear a little bit about the age of the patient and whether they got prior conduction disturbance, risk of pacemaker, etc. I think both valves work well here. The object of this is not to say who's right and who's wrong in terms of sizing. The object is to get people to think about, in a bicuspid, how much calcium is above the level of the annulus and to consider whether they need to, how aggressively they need to predilate and whether they need to, on occasion, take a smaller valve. That's all. It's not to say who's right and wrong. Gintis, you're going to tell us who's right and wrong.
The penalty could be, if it's truly bicuspid, and meaning it will not open, then your penalty could be infolding and stuff, or like seating down due to the stored tension and stuff.
Yeah.
But if it opens, that's certainly no penalty with high coronaries with reasonably large LVOT and sinus, and even a bigger one would work just fine.
Yeah, perfect.
But I fully agree with your comment that you made that if you would go for a 29, I would also try to aim high, because you have to know that in your 29 valve, the waist, it goes to a waist of 23. So if you would accept here a lower implant, let's say 4 or 5 millimeters, you may not have enough. Yes, then you may not cover that annulus range. So then if you take the decision, I think you could do it also. I think you could do it with both. If you take the decision to go 29, I think you should really aim for, I would not go to 0, but I typically more a 1 to 2 millimeter implanter then. But if you're 34, then it's less important, so I think. Yeah?
Okay.
You're implanting a bicuspid that's calcified, you go to 1 to 0. And I agree with you, that's what I would do.
Yeah.
But there is a bit of concern by many that with this kind of valve, you might have to post-dilate.
Yeah.
And if you're at 0 with that degree of calcium, like a full, you might embolize. So that's something.
Tobias, what did you do? Let's see.
Well, I need my slides and I'm under pressure. So many good suggestions.
Okay, we can bring your slides up.
So let's see what we have done. I want to share with you 3 learning objectives. So first of all, we have to choose the strategy for the patient. And you already saw the CT, and now you get the patient data. It's a male patient, very young patient, and therefore the heart team at our institution looking at all these diagnoses And also taking into consideration that he also has coronary artery disease, we opted for surgical aortic valve implantation and coronary artery bypass. But there was a problem during the surgical therapy. It was a futile surgical aortic valve replacement due to ineffective ACT. They weren't able to get any significant anticoagulative state during the surgical procedure and therefore only performed off-cap cardiac surgery, bypass graft towards the LAD. And then patient just woke up eventually, had a good coronary result, but was given back to the heart team. And then the team just sat together again. And the CT images you already know, but what you haven't seen, which is very, very important in these low-risk, intermediate-risk cases, is also that we are able to see whether we are able to go femoral or not have to go for alternative access. So, but what we are able to see right here and able to follow is that the access is just quite good and also no tortuous anatomy. So, choose a strategy. Well, the surgeons didn't want to go for another surgical case, so surgical strategy. So we said we go for TAVI.
So Tobias, if the surgeons couldn't get a therapeutic ACT, how did you get a therapeutic ACT? Just change the vial of heparin?
No. We, like you may have seen, we did some more diagnostics and we're able to see this 0.7 83 deficiency. So in advance, we were able to correct this issue, and we had a plan with our hemosthesiologists and were able to get an effective ACT.
Lovely.
CT images you already have seen. We even measured a little bit lower than the numbers you have seen by Darren. We did measurements on annular level, we did measurements on the level of the raphe, and like the educated guess, which I placed within this, in this height. And then the third point, which was already mentioned by a colleague from over there, was that we used the third information, just more imaging information, and put in a 24 millimeter balloon, which was a VAX3 balloon, and took also this information. And what we are able to see right here is that that we see the raphe and the calcification. What do you think? Any rupture?
It doesn't look like it moves a whole lot, right?
So it was your suggestion. What do you think?
So
does it break? Or?
To me, it appears it does move. Actually, if I look at it, it does appear that it's going more vertical when the balloon is fully inflated. On the other hand, we have absolutely no leak next to the balloon. Balloon is completely stable. It's a 24 balloon. So if I was having doubts 29 or 34 after this BAV, I would certainly take 29. I would have no doubt about it after this one. So that would be my take on it.
Yeah, you know what? I've done this before with a 10 millimeter balloon, and I had a beautifully stable balloon with no leak. So I don't know that the balloon stability and leak around the side really helps you. I think it can add to what you think. I would look at this and I would think, ooh, that balloon's not open. So I would think about dilating again, dilating with a bigger balloon, ensuring that I had it open before accepting that as a balloon.
I would personally be a bit scared going with a bigger balloon than 24. I mean, you can also risk here. You can lose something, yes? You can have annulus rupture. I would be in bicuspid.
Or maybe a non-compliant balloon, right? A VAX3 is a pretty compliant balloon.
Right. I think the fact that you have that indentation on the balloon also, to me, arguments gives extra fuel to defend a 29 choice, to me.
We saw a little bit of calcification in the LVOT. We also have back in our minds.
LVOT calcium?
Yes, a little bit with a CT scan.
For sure.
Yeah.
Christian.
The question is also, what is the objective of pre-dilating a bicuspid aortic valve? So is it sending some cracks into the calcium? Is it like opening some stuff to advance the valve? Is it really coming up to the real diameter that we want to achieve with the valve? So I wouldn't be that aggressive. It's a Zupka balloon, right? So rather not really non-compliant balloon. That's totally sufficient. Yeah.
Okay, so you would do an extra pre-dill with a non-compliant balloon.
Yeah, maybe a 23 balloon would be sufficient. But I saw that you didn't use a Safari or Confida, right?
No,
That case.
that's correct. It's a Landerquist wire.
Okay.
So still stick with
you and Stan are sticking together, huh?
Yes, it just was gut feeling. And
okay.
well, I heard all the talks from the US, but nevertheless, with this bicuspid anatomy and large, huge anatomy, I wasn't able to give up the Landerquist. Okay, so let's continue. But what is very important, also looking at this balloon, is that our aim was not to crack the functional raphe or to really push it aside aggressively. And you're also able to see this if you look at the numbers of the minimal diameter, which is 25 or 23. So with this 24 balloon, we are on the lower part of the annular measurement. So careful.
Can I ask an audience a question? With the patient's age being 63, do we adjust the depth of implant in this patient? Because there's the here and now, and there's lifetime management. And I don't think we measure the sinus heights, Darren, but we can assume that.
Okay, so anybody, so you're thinking, Stan, some people would say, let's get this valve lower because we might need to do a TAV in 10 years' time. Equally, the offside of that is that you might get a pacemaker if you go too low.
But I'm not saying 60, but more towards the 4 than the 3 to 4 than the 0 to 1, because
I don't know. Anyone got an opinion on that? Anyone go higher or go lower?
I'm just asking for debate, not saying I would do it that way.
Anyone going to take this one?
Here on this side, they have been muted.
Up, there you go.
I mean, I know this is a Medtronic session, but lifetime management. Why do you go for a supraannular valve to begin with? Why don't you? It's a big annulus. You could go for a balloon expandable valve and implant it like normally, and you just have to be careful that you don't press the bunch of calcium nut into the sinus wall. But otherwise, that would be a fairly good choice as well.
Yeah, I mean, it's an argument, right? I mean, the other side of that argument is you put a supraannular valve in a 63-year-old with multiple comorbidities, with coronary artery disease, and he gets 10, 12, 14 years. Maybe he doesn't live that long. So maybe you get better hemodynamics with a supraannular valve and less concerns about redo. Nevertheless, I think it is incumbent on us to make sure that we have a redo option in these super young patients. But with sinuses of 36 millimeters, I think that we can put any valve in this and revalve it in due course. That would be my opinion. Now, you'd need to do that specific analysis, but I think you can revalve this in 5-10 years for sure, if it failed.
And although balloon expandable valves have shown to be useful, the effective eccentricity in these valves, as shown by Paul Sharaja and his group, that if you don't get pure circularity with a balloon expandable, the durability may not be as long.
And annular calcification in this particular case.
LVOT again, calcification in this case. So.
I think there's always a conversation to be had. But Tobias, we need to see what you did because we're on the clock. So we combined all three discussion aspects right now, sizing at annular level, raphe level, and balloon sizing. We chose the Evolute FX 34. So what was also discussion, only a very short discussion or images in the talk, also in the main arena today, is the head marker. And with the head marker, it's a little bit a disturbing image, but nevertheless, this should be a pigtail, and this is the outer curvature. And then this is the head marker, and in fluoroscopic images, this is outer curve, and this is inner curve. And with the FX, I think we are able to follow the head marker and to control the head marker. With the former Evolute systems, to be honest, I did not bother very much about the head marker because of the tension you put into the system as soon as you rotate in the descending aorta and try to get the position in and to hold the position above the arch and the ascent. So real big difference with the FX. And this is the case. You see now the ascending aorta, and you need the LEO30 to see it, to see the outer curve. And within the outer curve, the head marker is on the outer curve. And then coming down, we are now in a near cusp overlap view. And this is, well, the near center front head marker.
here at this position, but nevertheless we said we are almost there, and now we proceed with the implantation and then check for the dots whether we have got this 2 and 1 configuration which is favorable. Another aspect which we already discussed is that we start at 0, not that much tension in the system, not this 5 to 7 millimeters diving down. Therefore, starting at 0, and you see that already the marker band is above the inflow, and therefore now you dive down to 3. And then this is an aspect, well, some people also in the talks from the US when we were trained with concerning the FX says, well, don't remove your detector, just stay there and only look at this pigtail and the contrast and the depth of the valve, and that's it. I like to remove the parallax here with going most of the times a little bit further in the caudal position. Then you see this gold markers 2 and 1. Then controlled fast pacing and pulling back the capsule. Any question at this point of the implantation strategy?
The markers look great there. Huh? I mean, they already tell you that you've got two of them overlapped. So it looks like you've got commissural alignment even before you complete.
I don't understand how the 3 dots help with the commissural alignment. How do you handle the valve based on what you see in the 3 dots that I can barely see, to be honest? That's one. And the other one is, what do you do with the hot marker when you are in the ascending aorta is not in the right place? How do you change your implantation to achieve commissural alignment?
Great questions. Okay, question number 1. You come up, you start with your flush port coming in, 3 o'clock. You get to the ascending aorta in LAO. It's not on the outer curve. How do you adjust with the FX?
Well, the first movement is a very slight movement coming from 3 o'clock to 2 or 1 o'clock. And then you, in most cases, you will able to see in the LAO 30 that the head marker is rotating towards the outer curve. So it's only a slight motion or slight grip on the system. Okay. And this is very important because this is the first step. And then if you go towards the arch and now check, and why do we do this? Because we know there's the head marker and 90 degrees besides the head marker is 1 commissure. And this is the idea. And the valve is always in the same position within the capsule. So we know how the valve is crimped into the capsule. We know, or we see the head marker, and 90 degrees from the head marker is 1 commissure. And the gold markers also, they mark the commissures. So therefore, I know that with this gold marker here on the inner curve, there's a commissure. And the 2 to 1 means after implantation of the valve, then I check for configuration of or placement of the gold markers and coronary orientation, that I've got no commissure in front of the coronary.
I made a drawing on top, but Tobias, I think due to sake of time, we still have another case, so I think you should move on and show what you did and then the end result, and then move to the next case. Yeah.
So then, this is very important. We use 2 views. We check in the cusp overlap view for depth and the gold markers 2 and 1. And then we definitely need a second view. Like Stan said, we have to check for the LAO, the left coronary cusp, where is our valve, how deep is it? Because with a symmetric implantation, we really have to check that we are not too high. There is the possibility to be too high now with this system, centering precisely and symmetrically in the native annulus. In this case, we were satisfied with the position, slow release, no push or pull on the wire, fast pacing if you like. We weren't satisfied with the expansion and the inflow, and we saw some mild aortic regurgitation. We did the post-BAV with a 24 millimeter balloon, and this is the final result. I don't show you the second view, not the LAO view. This is an RAO caudal with 3 millimeters on the non-coronary cusp. So choose an implantation technique. I think it is the cusp overlap technique with a little bit of FX adjustments and commissural alignment because it's doable right now and it's quite easy. Thank you.
Right. So first, any questions about this case still? We're open for any questions, comments.
Result, by the way, I think a valve completely opened. So I really doubt that it was a bicuspid valve. If your cusp overlap, come on, I mean, look at that cusp overlap technique, completely opened valve, touching the LVOT. That's a perfect result. Nice height, no leak, nice post-dill. I would say it was almost a zero implant, exactly how I like it.
Yeah. So good result, no PVL, and perfect commissural alignment in this patient, right? I mean, honestly, the big difference with me with FX so far in my limited experience is that commissural alignment is perfect, and that's huge for younger patients.
So I hope for the colleague there that it's clear now how the commissures still not.
Come down to us afterwards. We'll go through it with you.
I think we still.
And if anyone else is unsure, we can do it afterwards.
Can we get Can we get the iPad on? Can we get the iPad on? It takes only 30 seconds to explain it. Yep. If we get the iPad on.
Can we bring up the iPad? Henrik, you have a question?
If you work in a right-left cusp overlap view, what does it mean, right-left cusp overlap view? That means on the fluoro screen, you see, this is the RCC and the LCC is behind it. Yes, that's the right and the left cusp, they're overlapping. The non-coronary cusp, okay, the non-coronary cusp is you isolate on the left-hand side of your fluoroscopy. You follow that, yes? So by doing this, because you overlap the right and the left cusp, the commissure between these cusps is strictly oriented to the right-hand side of your screen, and the two other commissures, they're overlapping to the other side. You follow that? Yeah, okay, if they are not. So that's why you want to have that 2-1 configuration. If they are not, when you arrive and it's still in then what the official recommendation is that if you really think it's super important for your patient commissure alignment, that you have to bring it back into the descending aorta, make a 60-degree clock, for example, and you recross, yeah?
I think that's really important. This is not like the accurate neo, where you rotate the device in the ascending aorta. It doesn't work that way. The device, literally 2 fingers, you can get perfect commissural alignment by rotating it in the descending aorta. Once you pass into the ascending, don't rotate it because the torque is not transmitted. If you find when you get there that it's not perfectly commissurally aligned, you have a choice as the implanting physician. You can say, well, I've come this far, I'm going to implant the valve. That's what I would do, and accept near commissural alignment. Or you can decide to resheet the valve, take it right back around the aorta, and do it all over again. Personally, that's not what I would do.
All right, Darren, I think we have
Henrik,
10 minutes.
You got 10 seconds, and Ole, you set up your case, huh?
Yeah.
On your experience, how to remove the parallaxis when the Evolute starts to open up and you have parallaxis. Is it helpful to remove parallaxis, or
while you're expanding?
On the other hand, you have less information on implantation height, isn't it?
Yeah. Well, my strategy, but there's different strategies. What I like is to go to the strict cusp overlap view. If there's a little bit of parallax, I just correct by adding a little bit of caudality in it. Or you can someday like to add 5 caudal and 5 REO, if that's technically feasible there, because then you stay on the S-curve. And then you do your expansion. And as soon as I started my expansion, I'm not halfway during my expansion going to change my fluoroscopic view. I don't do that, personally. Maybe some people do. I don't. Then I like to expand it under some pacing, 130, 140. You do the expansion 80%. And then you go to an LAO. Why do you go to an LAO view? You go to an LAO view because in that way you kind of more or less isolate the LCC cusp on the left-hand side of the patient on the right-hand side of the screen, and you overlap more or less the other two, and then you make your assessment of your depth on the LCC. You can, in an LAO, you can only make a very accurate assessment of your depth compared to your LCC, and the other one to the NCC. Yes, that's it. I think we have really 10 minutes only. I want to show you this case still. So a 75-year-old patient, also treated 2 weeks ago, Hypertension, hypercholesterolemia, obesity, BMI 38, classical, and permanent AF, referred for TAVI. So this is CT. You see first, large anatomy, perimeter 96, yes, maximum diameter of 33.5. Perimeter derived mean 30.6. You see bicuspid-like, I say there bicuspid-like, I'm careful, we're totally, it's not bicuspid, but it's a little bit, the sinuses are a bit asymmetrical. Personally, I think it's tricuspid, but it is a little bit a more asymmetrical aspect of the, and we have that calcification, you see also a calcification at the annulus, which doesn't make this case easy, but that's not even the worst. The worst has to come. You see it's an angulated aortic arch, and it's actually a really horizontal aortic root. Here you see on the S-curve, you see this S-curve is extremely vertical. So we know it's a very vertical annulus, very horizontal aorta. This is not an easy case.
So who would take an Evolute Pro Plus for this? Yeah, I wouldn't either. Who would take an Evolute FX for this? It's different. It's a different system. It's more flexible.
So look, I thought it was a good case for it still, and I wanted to test the system too, and I thought it was a good choice for this patient. But you see, even just on that aorta, it's extremely, enormously curved, so it's a real test to the system. Good femoral axis, that was not the issue. So right femoral axis, 16 French introducer sheet. In this case, I think still it's maybe clever to use the Lundquist. Then it's a double curved extended stiff guide wire, which is almost like a safari, to be honest. It's not like the Lundquist like we know from the past. Predil 24 and an Evolute FX 34. So what did I do? Here, first pre-dilatation with the 24 millimeter. Went smooth, no problem. I think the wire is properly positioned. And you see what I did. So you see already here why, maybe if I can, I don't know, I don't think I can pause it. But what do I have here? So first the head marker at the outer curve, which is important for the crossing. I do the crossing very slow. I know it's a very angulated arch, and I want to show that it goes smoothly across. What I did in case of, I had a snare introduced from the left radial, not knowing if I would use it, yes or no. That takes only 30 seconds. It's just you put in a catheter, put the snare in, and you cross once with the wire, and you forget about that snare. I mean, you leave it there, and all the manipulations you do across. But if I would have a problem now crossing, making that real horizontal loop and getting the valve through my native valve, I can go back with my Evolute valve, put the snare across the nose cone, go down, pull it a bit up, and I would easily cross. Yes, that's how we do sometimes for extremely challenging valve in valve cases, etc.
So Ole, the snare is there not to help you cross the arch,
no,
but rather to get you up and across the valve.
If I would have trouble now with the next step, So here you see now it's the matter of crossing this valve, and I think here really it's the improved Evolute X nose cone profile that really helped me sliding rather easily. I do very careful. I'm always careful with the procedures. I never push a lot. So it's like heartbeat per heartbeat. I push it down, and you see that nose cone that it's much better tapered. That I'm not sure if with my Pro Plus I could easily do this. So I go easily across. If at this stage I would push and I feel like I have to push too much, I would go back into my arch, put my snare across, follow, pull it up. Yeah, but I didn't need to use it.
This technique consistently with the snare.
Yeah. No, absolutely. I mean,
Stan, say that into a microphone. We didn't hear you.
I said I used to use this technique. I think it's the appropriate technique, and it was by force of habit with the Evolute Pro. With the FX in the last year, I have not needed to use the snare once, and I've become a bit more lazy.
But look, I mean, this was only my case number 6, I think, from Evolute X. Yes, so it's like I didn't know how this was going to behave, and I think that nose cone looks like a trivial thing, but I think it really helps, even for vascular access, reduce complication, all that with the exchange there. I think I like that nose cone too, and it helped here in the crossing. And then we position, this is cusp overlap. We start there, as you said, Stan, also just at your 0 level. We don't start mid-pigtail. We give some pacing. We expand them. This is typically a pacing of around 120, 130, max 140, I think. And then this is the expansion. There's quite some leak to see here, but that doesn't always says a lot. I mean, we also gonna post that later, I'm pretty sure. And I think from depth, it's on the I want to play safe also, of course. It's this pyramid at 96. If I go implanting this at 0, and I may have to pulse-dilate, I may work myself really into trouble. So I think I have a depth here of around more or less 3 millimeter. Yeah, that's where the dots are, yes?
Yeah. And already, Ole, it's actually pretty impressive on the left side, right? The left side is not super deep.
No, but it's not super deep.
Yeah,
it's
good.
more symmetrical. It's around
much more coaxial, huh?
3.2, and you have maybe 4 millimeter more. Indeed, that's something what I appreciate, that it's kind of more self-centering. That's due to the flexibility of the catheter, of course. If the catheter is more flexible, you can get this valve which orients itself more spontaneously central into the aorta. There was a cusp overlap. And then here, slow paced release. I think this is not a strict cusp overlap. We can go back to be sure. Look, in the beginning I started for sure. No, seems cusp overlap. Yeah. Okay. So then we go for a slow release. I think that was also nicely demonstrated by Tobias. If you go there very slowly, I like to grab on all the calcium you have, you like to grab on. And then because I knew I had seen my valve, there was still some leak before release, I didn't even go in with a pigtail and change out. I go immediately with I took a 25 through, which is the largest diameter size you can go. Because it's such a big anatomy, I have nothing to lose. And you see how high I place the balloon. It's very different from what Tobias does. But I don't like to put my balloon very deep into the LVOT. I'm always afraid that I may damage some conduction or something. So I like to keep it high. And
we do need to be careful in terms of the size, the maximum size of a balloon, right? Particularly with non-compliant balloons like the true balloon, right? That the minimal diameter of a 34 is 24, and so 25 true balloon is the maximum that we should be using. We shouldn't be taking more, or we risk tearing the commissures. And it's the same with every valve.
Yeah.
With every valve, there should be a maximum you use for the post-dilatation, because all those commissures are sutured in, and you can tear them. So
that's true. There's the waist of a 34 is 24, so you can add 1 millimeter, and then the non-compliant, that's the max. So we did that immediately, and then I had the result. I checked it. Maybe can we replay it? Maybe I can replay it from here. So I think we had a great result in this really challenging anatomy. The day after, there was only a trace PVL on echo, no conduction disorder. You see that atrial fibrillation. The QRS was unchanged, 92, and the patient went the day after home. So I think there were really a lot of challenging aspects on this case, which made me also a little bit nervous before the procedure, but I think Evolut FX really helped me. It proved to be an improvement to me and make my patient have a safe and procedure with a good outcome. Yeah?
Okay. Questions about that case for Ole? Yeah.
I'm sure many people would have done differently, so it could be, or maybe some thought, yeah, this may be crazy, you do this way, or maybe I would like to hear some comments.
Shouldn't be the one marker, a single one marker on the right side during implantation, which I didn't see that.
No, to be honest, I didn't have attention for that during this case, but let's go back. Oh, can we have it?
Yeah.
That was not one of my primary goals, to be honest, to get commissural alignment. I was just happy to do this case safely and get the patient really good outcome. And this anatomy was so enormous, aortic root, that I mean, but we can look back on it. I don't know.
This is one of the anatomies that makes it difficult because of the torch wasn't the aorta you had and the unwinding. If you look back at that picture though, it was one, then there was the middle one was slightly off the center, and then one on the right. This is slight commissural misalignment, but then you also have the C-tab in the right position. So overall, this will not be misaligned. It's slightly misaligned.
Yeah. Joe, can we get the iPad up? So in terms, I think, of what Ole ended up with, he ended up with this in a cusp overlap view, right? In a cusp overlap view with perfect commissural alignment, you should get this, one on the bottom. Right, he got the one on the top, which means that there is some degree of commissural misalignment. But with the C-tab where it is on the inner curve, you probably have 30 degrees misalignment. I think the difficulty is that, of course, with this system, even though it's much easier to align, as I mentioned, it's a really nice feature. With this kind of hostile anatomy, as you take it around the arch, you are going to have a little bit of rotation of the system. And like we spoke about with that gentleman, you have a choice. Your choice is to take it back and to do it again. But I think with this type of anatomy, awesome result with mild to moderate commissural misalignment. I would take that personally.
It's a nice case. My question is about, because of the tortuosity, would you use like a stiffer system, or would you pre-dilate first? Would that help you?
Would be pre-dilated.
Okay.
Yeah. Maybe if we have 1 minute, I have some backup slides.
You've got 18 seconds, so it's not bad.
I'll do it in 18 seconds.
But I think with the stiffer system or the stiffer wire, the question is whether the Landerquist is the wrong wire.
Yeah.
Because it's working against the FX.
Yeah.
So this is something we have to, learn.
Figure out. Yeah. And sometimes you think a Lunderquist is going to help me and it doesn't, and you switch it out. The other thing is to remember that the stability layer that sits on this new system now is stiffer. So yes, we've taken out a spine, so there's only one spine now, but the stability layer actually coming around the arch that ends at the top of the arch actually is stiffer. So that gives you that more coaxial alignment. So whether in these type of very hostile anatomies, going with a slightly different wire is beneficial or not, I think we have to learn that, right?
We don't know. Anyway, the last 30 seconds and then we can happily go. This is maybe not relevant so much for the Evolute FX, but what I would have done if I had the Pro and I had to treat this patient, me and my colleague, we would have definitely gone for using a long dry seal sheet. You know, so if you have a very tortuous or very angulated, you see extremely tortuous descending aorta, severely angulated Gothic aortic arch, coarctatio-like aortic arch, aortic arch with a lot of plaque in the arch. You don't want to scrape there in the arch. So what we do and what we did for a couple of years, like the last 3-4 years, is using a 65 centimeter long dry seal sheet, 18 French, which goes all the way over here. So you introduce just a Lunderquist wire, you put that long dry seal in, and then you do everything from there. You come out with the valve at this level. And then it's actually, so you avoid all these complexities, and then all the maneuvers you do is one-to-one. And we actually did almost, so this is not even a very extreme case, but for such a case, what we do, you see this is the long dry seal. It's maybe not in the good view here. We typically do it in the LAO view, but you see you cross that long dry seal sheet over the arch. Yeah, so there's no big penalty you pay here. And then what you do is from there on, you see the sheet is completely in the ascending aorta. Yeah, so you avoid all this complexity of Gothic arch or atheroma in the arch, and then even your implant becomes easier. This was all with Evolute R and Evolute Pro and Pro Plus. So, and then we do the implants. So we did now 90 plus of these cases with a long dry seal with Evolute. It was easy TAVI delivery, 0 vascular complications and 0 strokes, and that was cases with like shaggy aortas and all that. Improved one-to-one depth implant control. But I think now, I didn't use it in this case because I really wanted to test the FX system, but I think maybe in the future I maybe still do it because I like it that much. And I think even it reduced my stroke rate in these challenging cases. So that's all just to share with you some tips and tricks in some challenging anatomies. Think out of the box, try to optimize really the outcome of your patient. And I think we can almost conclude with that. Maybe Darren, you make the conclusive notes on this session?
Yeah, so look, I think we've seen a couple of challenging cases with the technology that's new that we're learning about. I think all of us think that the nose cone is a big advance in terms of vascular access. I think removing the second spine really allows us to get commissural alignment in the vast majority of cases. The gold markers are going to really tell us about implant depth. I think I've been implanting a little deeper, so I've got some learning to do in terms of getting those gold markers really at 0 to optimize my implant depth. And then getting that valve a little bit more coaxial. I think Stan tells us in his experience, it's much easier to do. So we have a new technology. We need to learn and share experience in Europe and try and get the same great results that Stan reports from his US series. But I think it's certainly great to have a new advance that's going to help us to treat our patients better. So thank you for coming along and for listening to our cases and putting up with us. Thank you, Medtronic, for sponsoring the session, and enjoy the rest of the meeting tomorrow.
Yep.